Then I lost my vision.
Skin signs are absent or unrecognized in up to 20% of anaphylactic patients.
Protocol adherence can kill a patient.
Kunis syndrome? Kunis syndrome? Kunis
I think it's
syndrome?
Kunis.
Is it Kunis?
I don't know. Hey guys, welcome to another episode of Curbside to Bedside. Today you're joined with your regular hosts, Ryan and Floyd. Ryan, you want to tell them about an event we have coming up in March?
Sure. We have the March 9th symposium at Eastern Kentucky University at the Emergency Medical Care Program in the Stratton building. And basically what we're doing is about 30-minute long lectures in the SMAC or TED form, or TED Talk form rather, coupled with a lot of didactic-based skills. So you won't spend a lot of time in a seat, and you'll spend a lot more time actually practicing what you're being taught.
And this is called symposium. The key word there is sim, S-I-M, posium. There's going to be a lot of simulations, and you're going to get your hands dirty. We wanted to bring it to you guys first because seats are limited, so you need to sign up ASAP, and all this is free. So if you want to hear us live, then sign up for this event. We hope that you won't be disappointed.
And it's 8 hours of CAP-ACE approved education. Floyd will be presenting. I'll be presenting. My station is likely to be a actual bloodbath, and we hope to see you guys there.
And in my station, you're going to have to draw up some medications, and we're going to make it kind of a simulation-based medication administration. Email us, let us know if you have any questions. Are we ready to start?
I think we are.
All right, tell the folks what we're going to talk about today.
I think the topic for today is anaphylaxis, one of our classic presentations in emergency medicine, and probably one of the most satisfying when everything goes according to plan. So anaphylaxis is a bread and butter pre-hospital emergency. We're taught the ins and outs of how it presents and how to recite IM epidosages, which makes it seem fairly straightforward. However, that's not even really scratching the surface of the pathophysiology and the treatment modalities when you're presented with a patient who doesn't respond to the first, or the second, or the third dose of epi. So what do you do when that does not work and the patient continues to decompensate right in front of you? In fact, in the patient with anaphylaxis who is headed for the crapper, many of the traditional ways of managing these sick anaphylaxis cases are inadequate. And when you realize that your training did not prepare you to manage this sort of patient, it's too late. So we're going to do a deep dive into the topic and teach you what to do when IM epi doesn't work. This is sparked by an anaphylactic case that I recently had, where the patient had your typical skin signs and airway involvement. And the patient also rapidly responded to IM epi. So to kick this episode off, we have a special treat. I'm going to tell you about the day Floyd almost died.
So I have to make this super dramatic. And this was a day when I almost died from anaphylaxis. It was a sunny, balmy day in Georgia. I was in the military and lived just off base. I had recently poured a nice, tall, cold glass of bourbon and Coke as I peered unwittingly at the tall grass in the backyard that was a few weeks overdue. With some hesitation, I fired up the push mower in my flip-flops and went out into this humid jungle. After making a few passes, my feet started itching. And then I noticed there were these big red fire ants swarming me because I disrupted their habitat. I went inside and rinsed my feet off, but I didn't make it back outside because hives started popping up all over my body and I had this insatiable itch everywhere. I went across the street to a friend's house and I told them that I needed to go to the hospital. This pseudo-medical expert said that I just needed a cold shower. Luckily, one of my friends had appreciated this as a true emergency, and I was thankful that he did because I didn't. He grabbed his keys and rushed me to the hospital, and he drove with an extreme sense of urgency. We're pretty lucky that he didn't get pulled over because he had already pounded a few beers himself, and had we been pulled over, I likely would have died if there were any delay in getting me to the hospital, because at that time I had a sensation of impending doom as my body was covered in hives with this intractable itch. Then I lost my vision. All I could see was black, but somehow I was still conscious. Once we arrived at the hospital, He threw my arm over his back and basically carried me into the ER lobby. At that time, registration demanded my ID, so I mustered up the strength to pull my wallet out and throw it in her general direction. Luckily, some of the ED staff saw me and came out right away with a wheelchair. All I can remember is waking up a few hours later with a mid-level provider looking at me. In his words, he said, "You scared us."
That's pretty intense.
Yeah, I was pretty scared myself. I didn't know what was happening, but I knew it was bad.
Yeah, no shit.
It's probably the closest I've ever came to death. And I think that my case is probably one of the most clear-cut, straightforward cases of anaphylaxis that you're ever going to find. And most cases that you respond to are going to be clear-cut. I did not know that I was allergic to anything, but the history is telling. I had red ants all over my feet, which precipitated hives and itching, followed by a loss of consciousness. I never recall having any trouble breathing, though, which is kind of surprising since the respiratory system is involved in up to 70% of anaphylactic cases. I think that I probably just had massive vasodilation and some fluid loss. All of this happened quick. We're talking within 15 minutes, I almost died. I was essentially a ticking time bomb, and I think that if I had arrived at the hospital just a few minutes later, it's quite possible I wouldn't have responded to treatment. I don't know exactly how I was treated, but it seems patients respond best to IM epi early in the course of anaphylaxis, and if I had waited just a few more minutes, I may not have responded.
So should we review some pathophysiology?
Do we really have to?
Yeah, unfortunately.
Okay, well, if we have to do it, I think that it's best you kick us off.
I don't know about that, but I can tell you that there are essentially two types of anaphylaxis. The one we're most familiar with is IgE-mediated anaphylaxis. The second, and less familiar, is non-immunologic. As the names imply, one requires an individual to become sensitized by an allergen and therefore to produce the massive response. The other one does not. You may have never even heard of non-immunologic anaphylaxis, which is sometimes referred to as an anaphylactoid reaction. If you're not alone. But clinically, it doesn't make a huge difference because they are clinically indistinguishable, which in my mind means clinically irrelevant from the perspective of a pre-hospital provider. Here's a condensed summary of the patho so we can move along to some more interesting stuff. First, the host has to become sensitized to produce the massive response. An antigen, or an allergen, which produces the allergic response, invades the body. The antigen interacts with B cells that create antibodies. The antibodies are known as IgE, or an immune protein. IgE docks onto mast cells, which act as mediators. During the response, when the host gets reinvaded, the allergen docks onto those antibodies that were previously sensitized, causing mast cell degranulation, which releases cytokines, or messengers, that signal the release of histamine, which is probably the compound most responsible for the dilation of blood vessels and vascular permeability. Basophils probably have a large role in this response as well, but it seems that it's superseded by the role of histamine.
That was a mouthful.
Yeah, tell me about it.
Now, what about the non-immunologic response, or the so-called anaphylactoid response?
Now, this one is a bit less understood, but it's theorized that the allergen specifically targets mast cells. And that's pretty much the end of my research on it, but probably the most common example is when IV narcotics are administered and the patient has a localized reaction. So you can either get localized reaction or there can be a systemic release which can cause hemodynamic and cardiovascular changes that are not associated with the presence of urticaria.
I've seen quite a few localized reactions, and it seems that it's not that all uncommon. So let's talk about the definition of anaphylaxis, or how do we define anaphylaxis? Anaphylaxis, as defined by the World Allergy Organization in a position paper that they released in 2011, is a serious, life-threatening, generalized, or systemic hypersensitivity reaction. And another definition is a serious allergic reaction that is rapid in onset and might cause death. This definition is fitting because, contrary to the so-called criteria that we've all learned about how anaphylaxis presents, is wrong, because patients don't always present with the cardinal signs of urticaria, history of recent exposure, and pruritus. That's why the World Allergy Organization, the WAO, says that the case fatality rate is difficult to ascertain with accuracy. Anaphylaxis fatalities are often not diagnosed as such because of absence of historical details from eyewitnesses, incomplete death scene investigation, paucity of specific pathologic findings at postmortem examination, and lack of disease-specific laboratory tests. So it seems that the numbers of actual anaphylactic cases are underestimated because people do not appreciate some of the more subtle presentations of anaphylaxis. So the WAO, in this position paper, released some clinical criteria that is not what you would expect. The WAO outlines 3 criteria that's, quote, required to diagnose anaphylaxis, and the criteria is fulfilled when any one of the 3 are met. We're just going to provide a summary, but we'll put the full criteria in the show notes.
You either need obvious skin signs with respiratory compromise or hypotension with or without a known exposure, or exposure to a likely allergen for that patient with skin signs, respiratory involvement, hypotension, or GI symptoms, or hypotension following an exposure to a known allergen for that patient.
So basically, what I get is if the patient has obvious skin signs and respiratory compromise, regardless if an exposure is known or not, then just treat them as anaphylaxis. If the patient has a low blood pressure following exposure to an allergen, you don't need skin signs to treat them as anaphylaxis.
Absolutely. And these criteria do not replace good clinical judgment, but they are very sensitive and fairly specific and can also help you understand and recognize that anaphylaxis symptoms exist on a wide spectrum, and recognizing these variable and atypical presentations can help you provide life-saving intervention such as epinephrine administration.
So you mean patients do not have to have skin signs to have an anaphylactic diagnosis?
Absolutely not. Skin signs are absent or unrecognized in up to 20% of anaphylactic patients. Death can occur in just minutes from exposure, so rapid recognition and treatment is essential. When you're on the fence about whether or not a patient is experiencing anaphylaxis, history is important, but sometimes it won't be that straightforward. Sometimes the patient doesn't know if they're exposed to an allergen or not, but fortunately, epinephrine is an effective vasopressor for many shock etiologies, so if you don't know for sure if the patient is in anaphylactic shock or not, epinephrine administration is acceptable.
So what I'm getting is that anaphylaxis is unpredictable. The time course varies. The onset can be seconds to minutes and less frequently hours. Symptoms can be very minor and may resolve on their own, or it can progress rapidly to severe respiratory or cardiac compromise and then to death in just a few minutes. The best course of action for this unpredictable process is early administration of epinephrine, even if it's just for mild symptoms. Hypotension is not required to diagnose anaphylaxis or to administer epinephrine because it's in the early stages of anaphylaxis when it's most responsive to epinephrine.
So there's been little change to the treatment of anaphylaxis in decades. The core foundation is and will likely continue to be epi administration. The evidence for the use of epi is stronger than the use of any other adjunctive medications, which are probably okay to use unless they deter you from giving epi first. Epi treats airway obstruction, hypotension, and shock. Epi should be given intramuscular in the lateral thigh. This achieves higher peak plasma concentrations than IM or sub-Q epi in the deltoid. In emergent situations, you can forego the sterile technique and just give it through the patient's clothing. Once it's been determined that epinephrine is indicated, it should be administered quickly and without hesitation. Just realize that about 30% of patients will require repeat administration of epi. If a patient doesn't respond to IM epi or is in peri-arrest, they need IV epi and they need it quickly. So get an IV after IM administration. If you can't quickly get an IV, then get an IO.
The WAO provides little recommendation on the IV or IO dose, but they do say that if shock is imminent or has already developed, epinephrine needs to be given by slow IV infusion, ideally with the dose titrated according to non-invasive continuous monitoring of cardiac rate and function. If cardiac arrest is imminent or has already occurred, an intravenous bolus dose of epinephrine is indicated. Personally, I think that them leaving it at that is fine without any strong recommendation as to the proper IV dose. The greatest risk is not that we'll give too much epi, but that we won't give IV epi at all because we're not comfortable doing so or because we don't know how. I'm not advocating slamming a whole milligram unless, of course, the patient is in cardiac arrest, but there's a quick and easy way to give IV epi that is supported by the American College of Allergy, Asthma, and Immunology. The link to that article will be in the show notes.
Immunology is a hard word to pronounce when you're from Kentucky. So the dirty epi drip. So they recommend that you put 1 milligram of epinephrine in 1 liter of fluid. This makes the concentration 1 microgram per 1 milliliter. Simply start off by giving 1 microgram per minute and titrate up from there. Using a 10-drop set, you would need to give 10 drops to give 1 microgram in this concentration. This is a dilute concentration, which means that you have to give a lot of fluid to give the dose of epi that you need, which is great because if the patient does not respond well to epi, then the shock is probably persisting due to reduced intravascular volume. There's an emerging theory suggesting that anaphylaxis isn't as much of a distributive shock problem as once thought. And some articles we read suggested reclassifying it under hemorrhagic shock due to the amount of volume loss one may encounter. So not necessarily that you're bleeding from anaphylactic shock, but rather you're in a profound hypovolemic state. This seems a little extreme to us, but it really does drive the point home that people may need a lot of fluid. Some may respond well to epi if they have severe vasoplegia or massive vasodilation.
Some may respond well to epi if they have severe vasoplegia, which is massive vasodilation. Others may be completely clamped down and still remain in shock because they require large amounts of volume. Because of this, if you have to start an IO, start a humeral IO, which will allow you to give a large amount of volume of fluid quickly. There's a lot of stuff bandied about in regards to giving epi to patients with ACS risk factors. Needless to say, if the patient is in a severe shock due to anaphylaxis, then acute coronary syndrome is the least of my concern. Let's at least give them the chance to continue living long enough to worry about ACS. Coronary artery disease may be, quote, unmasked by anaphylaxis because the heart is a potential target. Let's imagine that the patient experiencing anaphylaxis has underlying coronary artery disease that has yet to be diagnosed. At baseline, that patient usually has enough supply to meet the demands of the heart if that demand is kept low. During anaphylaxis, the patient has a massive intrinsic catecholamine dump, which can possibly cause coronary artery vasospasm. Additionally, the patient is likely to go into shock if they're experiencing anaphylaxis, which decreases the supply of blood to the heart. The heart's demand then is greater than the supply, so these patients develop ischemic chest pain. Just because a patient experiencing anaphylaxis has chest pain does not mean that you should not treat them with epinephrine. The chest pain can be a result of anaphylaxis, and treating the anaphylaxis can improve perfusion to the heart, which would also treat their chest pain if you target the cause. This is where strict protocol adherence can kill a patient. If, for whatever reason, you think that you should follow the ACS protocol just because of the chest pain, then you will kill your patient.
The takeaway point from this is that the threat of potential cardiac ischemia is less than the threat of potential cardiac arrest. So we want to treat these patients aggressively to essentially allow them the chance to have an ACS type of event. But to segue from Floyd's point, I like to call attention to a rare but recognized clinical phenomenon called Kunis syndrome.
I think it's Kunis.
Is it Kunis?
I don't know.
Me neither. But Kunis syndrome, or otherwise known as an allergic vasospastic anginal episode, is typically described as a vasospastic acute coronary syndrome with or without underlying coronary artery disease. The main mechanism involves the release of inflammatory cytokines through mast cell activation, which leads to coronary artery vasospasm and or plaque erosion or rupture. Kunis syndrome has been described with multiple conditions, including a variety of environmental exposures and drugs. It's broadly classified into 3 different types. Type 1 occurs in patients without underlying coronary artery disease who have allergic ACS secondary to coronary artery vasospasm, which may lead to an MI. Treatment of the allergic event will usually relieve this, and in a type 1, they typically don't have any sort of plaque or thrombus that is ruptured. A type 2 occurs in people who have underlying coronary artery disease where an allergic reaction leads to a coronary artery vasospasm, and subsequently erosion of the plaque. And then a type 3 occurs in the setting of a coronary thrombosis or stent thrombosis, which really isn't terribly germane to our conversation here. As just a little bit of medical trivia for you to keep in your back pocket if you so desire.
So some physician named Kunis recognized the pathophysiology of how it relates to the heart in the setting of anaphylaxis and wanted to put his name on something.
I mean, can you really blame the guy?
So the next topic that we're going to discuss is known as empty ventricle syndrome. And this is probably what I find to be the most interesting thing that we're going to discuss today, other than the fact that if the patient's experiencing anaphylaxis, they need epi. Now, empty ventricle syndrome is something that has recently emerged, or I should say it's new to me. Empty ventricle syndrome is the effect that body posture can have on a patient with anaphylaxis. There was a postmortem study conducted in the UK that reviewed 10 cases of fatal anaphylaxis. They found that 4 out of the 10 happened after the patient was placed in an upright position. Of course, this is a small data set, but they found that the findings were consistent with PEA, and on postmortem examination, the ventricle was empty. They appropriately termed this empty ventricle syndrome. While this may or may not be a thing, I think that it could be. It makes sense. And I don't know if there's more data on this or not, but regardless, don't sit your patient up if you don't have to, especially if they are in severe shock or are peri-arrest. Now, this is not a categorical recommendation, but there's usually little reason to sit most patients in anaphylactic shock upright, with the exception of needing to actively manage the airway or if there's some other airway pathologies going on.
So your typical adjunctive therapies include things like Benadryl, beta-2 agonists like albuterol, or glucocorticoids. Now, I don't really want to go into a deep dive into these adjunctive therapies because it really detracts from epi being the staple intervention that's going to help the most. The other things have significantly less evidence for use during anaphylaxis and should never be considered first-line treatments. If you take nothing else away from the podcast, it's give epi, give epi, give epi. With that being said, you can give other stuff, such as antihistamines, to relieve some itching and urticaria, and a glucocorticoid might relieve protracted anaphylaxis and maybe prevent biphasic anaphylaxis. But again, these are adjunctive, second-line medications for a reason. They are not the life-saving intervention.
Beta-2 agonists are often given for wheezing that's not relieved by epinephrine. My personal preference is to give these routinely, and I give them early after epi administration, again as second-line therapies. The patient is likely going to need oxygen anyway, and there's no reason to think that albuterol works for wheezing during asthma or COPD, but not for wheezing that occurs during anaphylaxis. Now, Ryan, I heard you mention biphasic anaphylaxis. We have not talked about this. What is it?
It's basically where you turn your monitor up to 360 joules and press shock, except it's an allergic reaction. But in actuality, we haven't talked a whole lot about it because it doesn't occur that frequently. But it's entirely possible for a patient to be treated at the ED for an anaphylactic episode, get discharged, and then call you 12 hours later with recurrent anaphylaxis without ever being re-exposed to the initial provoking allergen. The pathophysiology of this is unclear, but it's a well-known phenomenon. Before I knew what it was, I have transported patients with biphasic anaphylaxis and thought they were either just re-exposed to something or might have been making it up. This is one reason why we should listen to our patients and not discredit them, because there's many things that we weren't taught and that the human body doesn't always follow the protocol.
Now, there are some patients that despite your best efforts, if you give IM epi and then follow that with IV epi, they will still be refractory to all of your interventions. There are a few alternative treatments that you can consider. In the patient in refractory anaphylaxis, you can consider transporting them to an ECMO-capable facility And there are a few case reports of this in the literature. Another possible alternative is methylene blue.
So I'm totally going to cut in front of Floyd because I actually really like this drug. Never given it, probably never will, but I just think it's super cool. If anything, because it's literally like this kind of really deep, awesome looking blue color, and I'm fascinated by simple things. So in the setting of refractory anaphylaxis, methylene blue may be administered concurrently with epinephrine. But why? Histamine, along with some of the other inflammatory mediators that are released during anaphylaxis, also release nitric oxide, which in plain terms blunts and inhibits the release of catecholamines and has also been identified as a culprit in systemic smooth muscle relaxation. Methylene blue will help to reverse this process by inhibiting the action of nitric oxide. It's also really cool looking, like I previously mentioned.
Clearly, only certain facilities are going to have ECMO capabilities. However, every facility should have methylene blue, but there may be a few facilities who think that epinephrine is the end of the treatment algorithm. And because of that, if there's a difference in transporting your patient to a local facility versus a tertiary care facility that's 10 or 15 minutes down the road, you want to consider that tertiary care facility, because chances are that those types of places are going to be familiar with methylene blue as a treatment for refractory anaphylaxis, and there's also a good chance that they are going to have ECMO capabilities.
And there's some pretty fascinating case reports in the literature that are out there. We'll provide some links to that in the show notes. Not necessarily a fringe treatment, but definitely getting further on down in the treatment pathway. And with that, Floyd, do you have anything else?
There's also the possibility that you'll have a patient who is experiencing anaphylaxis and is also on beta blockers. In these patients, you really want to consider glucagon. Patients who take beta blockers are particularly challenging because beta blockers limit the effectiveness of epinephrine. The patients might be resistant to epinephrine and have severe hypotension and bradycardia. Glucagon has a positive inotropic and chronotropic effect on the heart independent of catecholamines. So you can consider a 1 milligram intravenous bolus of glucagon. There are quite a few people who say they're not even going to consider glucagon. There are a lot of people who say that they're not even going to consider glucagon because we don't carry enough on the ambulance. However, there's quite a few guidelines who recommend that you start off at 1 milligram, and some say to go up to 5 milligrams. So in my opinion, if you have a patient actively crashing in front of you who is going to die from anaphylaxis, it doesn't hurt to try a milligram of glucagon. Guys, thanks for tuning in again. We hope that we're producing some valuable information. If there's anything you want to hear, shoot us an email. And please like our Facebook page and follow us on Twitter.
Yeah, while Floyd's stuck in the 90s with his emailing, feel free to get at us on Twitter or Facebook. We're fairly active on there. Check our messages pretty regularly. Wouldn't hurt to see a little flag showing someone took an interest.
Our status on Facebook is that we are very responsive still.
The most responsive, actually.
And we're gonna maintain that status for as long as possible.
It's like an eBay seller rating. You got to keep that up.
So, thanks for listening. This is Curbside to Bedside signing off.
See you guys.
Bye.